Hello everyone and welcome back to my channel. So I am back with another episode of Read Robbins with me. Today I'm going to discuss the chapter of inflammation and repair, which is essentially the acute and the chronic. So if you need any introduction, then please watch my previous videos. I'm not going to waste any more time here because it's a long and a lengthy chapter. So, starting with the inflammation and repair, inflammation is a response of the vascularized tissues that delivers leukocytes and molecules of host defense from the circulation to the sites of infection and cell damage in order to eliminate the offending agents. So, what are the sequential steps of inflammation? These are very easy points. I'm going to brush up quickly through them. First, there is recognition of a noxious agent, followed by recruitment of leukocytes and plasma proteins, followed by removal of the stimulus for inflammation and regulation of the response and tissue repair. So all of these are just paragraphs just explaining these points. I'm not going to go into those details. This is a very important chart. As you can see that what is the disorder and what is the molecule involved in the injury. So you can see that in ARDS, it is the neutrophils, in asthma, it is the eosinophils and the IgE antibodies. Glomerular nephritis, it is the complements and the antibodies and also the monocytes. Septic shock, it is the cytokines. In chronic inflammation, mainly the lymphocytes come into play. In asthma, like in arthritis, it is lymphocyte, asthma, eosinophils. Atherosclerosis, macrophages and lymphocytes. Pulmonary fibrosis, it is macrophages and fibroblasts. So these four important points, that is the rubber, tumor, calor, dolor, functiolacy. Now this is again an important difference. Okay, questions are being asked. So acute is very fast in onset while chronic is slow. These are very easy and not much concept oriented. So in acute you get neutrophils, in chronic you get monocytes, macrophages and lymphocytes most importantly. So tissue injury is usually mild in acute, but in chronic it is usually severe and progressive. So this is an important point, don't get confused over here. The local and systemic signs are prominent in acute and less in the chronic. The causes are the infections, tissue necrosis, foreign bodies, immune reactions called the hypersensitivity reaction. Now, what is the mechanism of the recognition of the microbes and the damaged cells by the immune cells in our body? So the receptors, there are some cellular receptors for microbes. Okay, what are these? The cells express receptors in the plasma membrane for the extracellular microbes and in the cytosol for the intracellular microbes. So this is an important point. For extracellular, you have the plasma membrane, and for intracellular, you have the cytosol where these receptors are present. Now, these receptors mainly belong to the toll-like receptor family. So, engagement of this receptor triggers the production of molecules which is involved in inflammation, like the adhesion molecules, the cytokines, and other mediators. So, I hope you understand that what happens is these cells, they will express the receptors, right, where which will ultimately bind with the microbes, and that will initiate the immune response, the inflammatory response. Now, what are the sensors of cell damage? That is the node-like receptor that recognize the diverse molecules that are liberated as a consequence of cell damage. Okay, now these receptors activate a multi-protein cytosolic complex called as the inflammasome, which induces the production of interleukin 1. This again recruits the leukocytes and thus it induces the inflammation. The gain of function of these genes are the cause of rare diseases grouped under auto-inflammatory syndromes that are characterized by spontaneous interleukin 1 production and inflammation. So this is a very, very important point, that in case of autoinflammatory syndromes, there is a spontaneous increase in the interleukin 1. Okay, that explains how this mechanism takes place. So these are easy part. Now coming to acute inflammation, now from here the important part starts. So acute inflammation has got three components. Number one, dilatation of the small vessels leading to an increase in the blood flow. Number two, increased vascular permeability of the microvasculature, enabling plasma proteins and leukocytes to leave the circulation. Number three, emigration of leukocytes from the microcirculation, their accumulation in the focus of injury, and their activation to eliminate the offending agents. So As you know that there are some vascular events and some cellular events taking place in this entire process of acute inflammation. So I'm going to talk about each of these in detail. What happens in vascular events is that first there is vasoconstriction, which is transient, okay, only for a few seconds or a few minutes, and then it is followed by the most important part, which is vasodilation. After vasodilation there is increase in the vascular permeability, and after which there's going to be stasis. Okay, to increase in vascular permeability has got some mechanisms. Okay, what are the mechanisms of increase in vascular permeability? Number one, there's contraction of the endothelial cells, which is immediate and transient. There's mild endothelial injury, for example the sunburn, where the response is delayed and prolonged. Retraction of the endothelial cells, where the response is delayed and prolonged. And direct endothelial cell injury, where the response is immediate and prolonged. So you can see these words are different from in different mechanisms, so these are important points. I will talk about these in detail now. So the vascular reactions of acute inflammation, they consist of the changes in the flow of the blood and the permeability of the vessels. Okay, so what is an exudate? It is an extravascular fluid which has a high protein concentration and contains the cellular debris. Now exudate and transudate, these concepts and these mechanisms will be clear when I will talk about in the chapter of hemodynamic disturbances. Here I'm not going to go into the details. Okay, please understand that the mechanism of inflammation is the most important part. So starting with the vasodilation, obviously remember that before vasodilation you have the vasoconstriction, which is transient. Then you have vasodilation, which is induced by several mediators like the histamine, which is the earliest manifestation of acute inflammation. It mainly involves the arterioles, and then it leads to opening of new capillary beds, which increases blood flow. And after vasodilation you have the increased vascular permeability, and after this process there's loss of fluid, increased vessel diameter, because of which there is something called as stasis. So you can see here something important to mention, that this is the transudate and this is the exudate. This is the normal vessel. So what happens in exudate? There is vasodilation and stasis, okay, and there's increased interendothelial spaces through which there's leakage of these molecules. Now what happens in transudate is that transudate mein there is an increase in hydrostatic pressure, very important. In case of exudate formation there is vasodilation, there is stasis, and there is increase in the interendothelial spaces, which is a part of inflammation. So exudate is linked with inflammation, but transudate is not linked with inflammation. Transudate happens because there is an increase in the hydrostatic flow, and therefore you will find that the proteins over here are not of that high content, because there is no inflammation, there is no infection here. It is just that there is an increase in the hydrostatic flow, whether because of venous obstruction or whatever may be the reason, and there's a decrease in the colloid oncotic pressure, because of which there is formation of this transudate. So this is the entire idea. I have highlighted these points. Just go through this, this numbers sometimes may be important for you. So, coming to what happens is after stasis, the blood leukocytes, mainly the neutrophils, will accumulate along the vascular endothelium. So, these cells will now start to marginate. Okay. So, what happens is these endothelial cells are activated by the mediators. So, if you see this is the blood vessel and these are the endothelial cells, these are getting activated by the mediators. At the same time, the neutrophils will kind of try to accumulate towards the vascular endothelium. Okay, in this process the leukocytes will now adhere to the endothelium. So I hope you're understanding the process. So once there is vasodilation and there is stasis, the cells which are there in this blood will now start to marginate towards the ends or towards the endothelial layer, okay, where it will ultimately get adhered. So let's talk about this now. What is the mechanism of increased vascular permeability? Just now I have mentioned this contraction of the endothelial cells, which is having an immediate transient effect. There is, I mentioned all these points here. There is mild endothelial injury, retraction of the endothelial cells, and direct endothelial injury. So by all these mechanisms, there's going to be an increased vascular permeability. Now, along with this vascular permeability, obviously the lymph flow is also increased, and that because of the increased vascular permeability, which leads to certain kind of inflammations like lymphangitis, lymphadenitis, etc. Okay. So this is the exact way that these vascular events take place up to stasis, where we have explained that there is margination of these cells towards the endothelial layer. The endothelial itself is getting activated because of these inflammatory mediators, and now these lymphocytes or neutrophils will now get adhered to this endothelium by some mechanisms which we will talk about in the cellular events. So coming to the cellular events, there are six points. Number one is the margination, as we have seen, then rolling, then adhesion. Okay, they will actually properly get stabilized and adhered to the endothelium. Then diapetesis, it will move out of that, right? So once it get adhered from here, it's going to move out. Then there's going to be chemotaxis, means they will move out. These neutrophils will move out of the blood vessel to the site of injury where it needs to do its function, and then there's going to be phagocytosis and clearing of the offending agent. So if we talk about the leukocyte recruitment to the site of inflammation, this is the main idea. The main idea is to fetch these neutrophils and bring them to the site of inflammation. Okay, and this journey of leukocytes from the vessel lumen to the tissue is a multi-step process that is mediated and controlled by adhesion molecules and cytokines called the chemokines. So very, very important. So what happens is, in the lumen you have margination, rolling, and adhesion to the endothelium. And after this adherence, there's going to be migration across the endothelium and migration ultimately to the tissues where it is required. So this, now you can see that here the main part, the most important and difficult part comes, because we want to discuss about how this adhesion takes place. So this adhesion, as you can see here, that um, there's some proteins called selectins and integrins which play an important role here. Selectins will help in rolling and integrins will help in adhesion. So let's discuss this, that when there is stasis, these white cells will now move towards the periphery. It will now move towards the margins of the blood vessel. So if this is the blood vessel, then this is the margin, and the white blood cells will now move towards the margin of the peripheral of the blood vessel, means they are assuming a peripheral position, which is because of this stasis in the blood. And this process of leukocyte redistribution is called as margination, means they are getting marginated towards the end, and this slowed leukocyte will send signal from the endothelium, resulting in a rolling of this cells. ठीक है. So before getting firmly adhered, they will first roll. ठीक है. If you think about an animation, then first these cells will kind of roll, and then it will start to get adhered over here, and then it will kind of move out of this epithelial cell by diapetesis, and it will go to the site of its action. It is something like that. So the attachment of these leukocytes to the endothelial cells is mediated by adhesion molecules, whose expression is enhanced by the cytokines. Okay. Now we will discuss these two kinds of proteins which are extremely important. Each of these proteins along with the name of their ligand is a very important question, चाहे वो आपके short note हो, long question हो, and especially in your MCQ based exam, all these words are very confusing and they're extremely important. So let's talk about the selectin. As I said, they play a role in rolling. The rolling is something which happens because of the selectin. There's so many selectins. You can see on leukocytes you have L-selectin, endothelium you have E-selectin, platelets and endothelium you have P-selectin. The ligands for selectins are sialylated oligosaccharides bound to mucin like glycoproteins. This tissue macrophages, mast cell, endothelial cell that encounter microbes and dead tissues respond by secreting several cytokines, including the tumor necrosis factor, interleukin 1, and the chemokines, which are the chemoattractant cytokines. Okay. Now, so there's an important question here, that what happens is the mediators like histamine and thrombin, they will stimulate the redistribution of P-selectin from its normal intracellular stores in the endothelial cell granules known as the Weibel palette bodies to the cell surface. So what is Weibel palette bodies? They are basically the P selectins which is stored in the endothelial cell granules. So this is again an important question for your exam. And now coming to these selectins, there are three kinds of selectins which are the most important: L selectin, E selectin, and P selectin. Now this is the place where the selectins are present, and this is the ligand on which they are binding. Very important. I'm not going to confuse you over here, so you will be doing it from this chart only. See here, pay attention and understand this part, that if you talk about L selectin is present on the neutrophils, okay, and it is binding with the Siley Lewis X on the endothelium. So the ligand is Siley Lewis X on the endothelium, and the molecule is L selectin on the neutrophils. This is how this binding takes place, okay, and that is how this binding takes place, and the rolling, is executed. So the next is the E-selectin. It is present on the endothelium, and the Siley Lewis X, which is present on the neutrophils, now will act as the ligand. It will bind with this E-selectin on the endothelium. Similarly, the P-selectin on the endothelium will bind with the Siley Lewis X on the neutrophils. So these, please understand, these locations are important. This L-selectin on the neutrophils will not go and bind with any other cell, but rather it will only bind with the Siley Lewis X on the endothelium only. So these are very specific for each other. So you must remember, that's why I've highlighted it in this way. You see, I've highlighted it using one color. Okay. Now, the coming to the integrins is a much more difficult part to understand. So understand that once they are rolling means they will bind, detach, and bind again. So if this is the lumen, then these cells will bind, it will again detach, it will again bind, it will again detach. So this is rolling. But then what is integrin? Integrin means they will completely fix itself to the endothelium. So these weak rolling interactions now give them the opportunity to firmly adhere to the endothelium, and this firm adhesion is mediated by something called as the integrins. And now you must know that there are some ligands over here also, which are very, very, very important questions. So what happens is, you can see that the TNF and the interleukin 1, they induce endothelial expression of ligands, mainly the VCAM1. VCAM1 is the ligand for the beta 1 integrin VLA4, and the ICAM1 is the ligand for the beta 2 integrin LF A1 and MAC1. So you understand these terms are so complex, right? So I have kind of tried to simplify here and tell you that, see, this is the molecule which is binding with this ligand, and this is the molecule which is binding with the ligand. So this is basically the integrins. So beta 1 integrin, which is VLA4 on the leukocyte, will bind with the VCAM ligand on the endothelium, and beta 2 integrin, which is the LFA1 and MAC1 on the leukocyte, will bind with the ICAM ligand on the endothelium. There's another, integrin, which is the CD31 or the PCAM1 on the leukocyte, which again binds with the similar molecule on the endothelium. So the molecule remains the same, and that is why it is called as homotypic adhesion, because the same molecule is getting adhered as ligand itself. Okay, I hope this point is clear. So now we have reached up to a point where the lymphocytes, where the leukocytes are now adhered to the endothelium. So after getting adhered, the next step is that this leukocyte will now migrate, right, through the intact endothelium, and this process is called transmigration or diapedesis. So now once they are getting adhered, it will migrate through this intact endothelium out of the blood vessel, which is called as the transmigration or the diapedesis. This is mainly present in the post capillary venules. Again, a very important MCQ point. So chemokines act on the adherent leukocytes and stimulate the cells to migrate through the endothelial gaps. Okay. Yes, towards the site of the injury, and this I've already explained you before. So once they move out of the blood vessel, they will now be called to the site of injury by something called as chemotaxis. After exiting the circulation, these leukocytes will move in the tissues towards the site of injury by the process called as chemotaxis. The most common endogenous factors are the bacterial products. Okay? These will act as the chemokines. The bacterial products, the endogenous chemokines are there, are present, like the cytokines, complements, okay, leukotrienes, and all of this. So understand that what happens is, initially in the inflammation, or in cases of acute inflammation, the neutrophils are predominantly present in the first 6 to 24 hours, which, very important question, these timelines are very very important, okay, which is replaced by monocytes in 24 to 48 hours, again important, okay. So this is a very important short note as well as a reasoning question in the undergraduate, okay, that why do you have neutrophils in the early stages of acute inflammation. So why the neutrophils are predominant in the acute inflammatory state? So these are all the reasons. See, there are several reasons for the early preponderance of neutrophils. So what are the reasons? Number one, they are more numerous than other leukocytes. Number two, they respond more rapidly to chemokines and may attach more firmly to the adhesion molecules that are rapidly induced on the endothelial cells, such as the p-selectin and e-selectin. So that means they get adhered more easily, okay, and more firmly. Number three is, after entering the tissues, these neutrophils are short-lived, and most neutrophils in the extravascular tissue undergo apoptosis within a few days, and that is why they will only remain in the first 6 to 24 hours, and they are not long lasting, okay. Monocytes not only survive longer but may also proliferate in the tissue, and that is why they became the dominant population in the prolonged inflammatory reaction. Means after 24 hours, the cell which is predominantly seen is the monocyte, again very very important, because they can survive longer, they can proliferate in the tissues itself, and that's why they are found towards the prolonged inflammatory states. So you can see here that all these things are I have highlighted here are having the same kind of concept. Okay, so after these cells, or these neutrophils, or whatever these inflammatory cells are ultimately reaching the site of injury, there's going to be phagocytosis and clearance of the offending agent. The two major phagocytes are the neutrophils and the macrophages. So now the function of these two cells ultimately is to catch hold of this offending agent and clear it. That is why it is called inflammation, because it's trying to combat whatever has happened to the body, and returning back to the original homeostatic state. So recognition of these microbes or the dead cells induces several responses in leukocytes, and is collectively called as leukocyte activation. The functional responses that are most important for destruction of microbes and other offenders are phagocytosis and intracellular killing. So by these two mechanisms, these microbes are going to die. Okay, so, for coming to this phagocytosis, what is phagocytosis? There are various sequential steps. Number one is recognition and attachment of the particle to be ingested by the leukocyte. So first, these particles have to be attached with the leukocyte for its engulfment. Next is going to be the process of engulfment by formation of a phagocytic vacuole, and then there's going to be killing of the microbe and degradation of the ingested material. Okay, so what are the phagocytic receptors? Mannose receptor, scavenger receptor, and opsonins. These are the receptors which this macrophage mannose receptor is a lectin that binds the terminal mannose and fucose residues of glycoproteins and glycolipids, which are found on the microbial cell wall. So you can understand that therefore the mannose receptor recognizes the microbes and not the host cells. Why? Because this mannose receptor will only bind with the terminal mannose and fucose on residues of the glycoproteins and the glycolipids, which are only found on the microbial cell walls. That is why this mannose receptor will only identify the microbes and kill them, and they do not attack the host cells. This is the reason why they do not attack the host cells, because they will recognize only those molecules of mannose and fucose which are present on the microbial cell walls and not of the host cells. Okay? Now these scavenger receptors, where now they will mediate the endocytosis, like for example of the LDL particles, and these macrophage receptors, it will again bind with the variety of microbes. Macrophage integrins, notably the MAC1, may also bind microbes for phagocytosis. The efficiency of phagocytosis is enhanced when they are coated with opsins. The major opsins are the immunoglobulin G and the C3b. So this is how the phagocytosis is taking place. This is how the the recognition of the receptor. As I said, the first step was recognition of this particle which needs to be phagocytosed. Next point is the engulfment. There's formation of a phagosome which will engulf the material, the microbe, and then along with that will again fuse the lysosome. Okay, that is how the process actually normally occurs, giving rise to a phagolysosome. And the last point is how that is being killed ultimately. So there's ultimately an intracellular destruction of the microbes and the debris. Okay, this again is an important diagram, all of which I have explained is mentioned over here. See how this is, how this I've explained, and this is what we are reading now. Okay, so killing of the microbes is accomplished by the reactive oxygen species, also called the reactive oxygen intermediates, and reactive nitrogen species, mainly derived from the nitrogen oxide. And these, as well as the lysosomal enzymes, they destroy the phagocytosed material. Okay, so this is how basically by the reactive oxygen species, basically there is intercellular destruction of the microbes. Now this reactive oxygen species, I'm not going to talk about this much. One point I want to mention is that the H2O2 MPO halide system is the most potent bactericidal system of the neutrophils. Okay, please understand that here is an important point I want to also mention, that this superoxide is converted to hydrogen peroxide. Okay, hydrogen peroxide is not able to efficiently kill microbes by itself. However, in the neutrophils, there is an enzyme called myeloperoxidase, which, in the presence of chloride, will convert this H2O2 to H2Cl, which is a very, very important antimicrobial agent. And this is how the neutrophils will ultimately act as an antimicrobial agent, because they have this enzyme myeloperoxidase which converts this H2O2 to hypochlorite, which is the active ingredient for antimicrobial activity. I hope that you are able to understand this part. So finally, there is destruction of these microbes by these reactive oxygen species. All these things are not that important. Now yes, lysosomal enzymes also kind of act on this. The neutrophils have two main kinds of granules. Number one is the secondary granules, and you have the primary granules. So these names are again important, just go through them. Okay. Now coming to the neutrophil extracellular traps. Now what is this? This is a very, very important short note. Very important short note. Okay. So neutrophil extracellular traps. Now what are these? These are basically what's happening here is that the neutrophils are getting fragmented, and from the neutrophils, these fibrillar networks are coming out into the extracellular space, and these will secrete antimicrobial substances. So basically, this is acting against the microbes to kill the microbes in a very larger and a concentrated format. Okay. So these nets are extracellular fibrillar network. Why extracellular? Because the neutrophil has gotten degraded here and the materials have come out. Okay, I'll talk about it in a few minutes. So these are extracellular fibrillar network that concentrate the antimicrobial substances. Okay, so these extracellular network will have these antimicrobial properties. Okay, at the sites of infection, it will kind of concentrate all the antimicrobial substances at the site of infection and trap the microbes. Okay, helping to prevent their spread. So the extracellular traps, they consist of a viscous meshwork of nuclear chromatin that binds and concentrates the granule proteins such as the antimicrobial peptides and the enzymes. The ROS-dependent activation of an arginine deaminase that converts the arginine to citrulline, leading to chromatin decondensation. So this is basically how it happens. Okay, once there is chromatin decondensation, there's also further action of other molecules like impure and elastase, which enter the nucleus, and they cause further chromatin decondensation of the neutrophils, ultimately culminating in the rupture of the nuclear envelope and release of the chromatin. So basically, from the neutrophil, now the chromatin is being released into the extracellular space. So that this is the entire mechanism, how these cells are getting broken down and how this chromatin is getting released into the extracellular space. And this nuclear chromatin, which has the histones and associated DNAs. Now they are a source of nuclear antigens, and as we can see, for example, in that autoimmune diseases like the SLE, where you can actually measure and see this nuclear antigens. Okay. So another important point is that in the cold abscesses, the Th17 response plays an important part. So this is again a very short MCQ. So coming to the mediators of inflammation, I don't think, okay, I think here I've missed out one. Yes, so this is again an important chart which you have to keep in mind and keep this marked for your MCQ based exams. So the origin is obviously the bone marrows. There's not much difference here, but what differences are there in the responses to activating stimulants? Rapid. This is a more prolonged response. The Ross species is rapidly induced by assembly of phagocytose oxidase. This is less prominent. Then degranulation is the major response, but there is no degranulation over here. The cytokine production is low, but this is having a major functional activity here. There's net formation over here, but there's no net formation over here, and the secretion of the lysosomal enzymes is prominent here, and this is not present here. Okay, I don't think I should go through this image once again, because I've already explained how this phagocytosis is happening, and ultimately there's killing by the Ross. You've already gone through this once. Okay, so coming to the mediators, I think this part or this chart is enough for you. So histamine, this source and these actions, you can just go through them. There's nothing much to understand here. It's just that what are the mediators, like you have the vasoactive active amines, lipid products, cytokines, etc. The cell derived mediators like the histamines, and all these granules and all. So then the plasma derived mediators like the complement protein. So this is just the names. There's nothing much to understand. The vasoactive amines like the histamine and serotonin. Okay, the prostaglandin, the arachidonic acid metabolites. Again, this is an important point. Vasodilation is happening because of this prostaglandins. Vasoconstriction because of these molecules. Vascular permeability is increasing because of these molecules, and chemotaxis and leukocyte addition is happening because of this. So again, this is a very very important, because you may gonna get confused seeing all these things. So just go through it once. I haven't gone through this in detail because I don't think that this is a potential high yielding area. If you have any particular input into it, you can obviously mention in the comment section. So then cytokines and chemokines, the tumor necrosis factor 1. Okay, they have a critical role in the leukocyte recruitment by promoting the addition of the leukocyte to the endothelium and their migration. Okay, the functions are endothelial activation, then activation of the leukocytes, the systemic acute inflammatory response. This is again a very important chart, because here you have all the cytokines and what the principal sources and the actions. Actions are fine, but principal sources are very very important. Okay, sources are very very important. From where we get the interleukin 1, interleukin 6, interleukin 17 is produced by the T lymphocytes, and obviously actions are also important. Okay, like interleukin 12 from the dendritic cells and the macrophages producing the interferon gamma, very very important point. Then interferon gamma is in turn is produced by the T lymphocytes and the NK cells, which activate the macrophages. So there's a very close interconnecting link between the T cells and the macrophages. Okay, I'm going to talk about it, this mechanism I'm going to talk about it. There's an interlinked relation between the T cells and the macrophages. They kind of have a mechanism of interconnection, and that's how they give rise to the formation of something called as the granuloma. So that is where all these cytokines will come into play. So this interferon gamma will activate the macrophages. Interleukin 17 produced by the T lymphocytes. I've already told you this before. The function is to recruit neutrophils and the monocytes. Okay, so all these are very very important. Now if you talk about all these things, I have skipped this is complement system. You can read this very well in your microbiology. Okay, complement is particularly important in killing of the Neisseria bacteria. Just a short point here, this is again important, the role of the mediators and what is the mediators which is released in all these conditions. Like in fever you have interleukin 1 and TNF. In pain you have this, in tissue damage you have this. So it's not that important, but you kind of go through it because this will ultimately give you some idea for the MCQs. Now what are the morphological patterns is again very very easy. There may be serous inflammation, means you just have got some exudation of some fluid. Okay. Then you have the fibrinous inflammation, where you find that the exudate develops when the vascular leaks are large and there's a local procoagulant stimulus. Then you have the purulent inflammation and the abscess. Then you have the ulcers. Okay, the outcomes is that they can be complete resolution, they can be healing by fibrosis or scarring, and it can progress to something called as chronic inflammation. And this is what I'm going to take up now. Okay,